Hey everybody, welcome to another live stream Q&A with NCAN. I'm your host Mike Wayman from NCAN. We're going to do something a little bit differently. This is on a Thursday, and it's because tomorrow is Rare Cancer Day. So we're going to do a little bit of a live stream Q&A for you. Today we have Dr. Garima Gupta out of the University of Miami. Out of the University of Alabama. We're really excited because Alabama is our next stop. It's our first conference this year. So we will be going to Birmingham, Alabama for our first conference this year on March 15th. April 5th, we'll be in Charlotte, North Carolina. You can get all information that you need on netcancerawareness.org and all of our social medias at netcancerawareness, at netcanceraware. And we also have plenty of fundraisers going on this year. The first one this year we have is the Flower Power fundraiser. Go over to netcancerawareness.org, go to the Zebra store, and that's where you can find all sorts of stuff. It helps NET patients. It helps further us along. So please help support us. So without further ado, our guest of honor here, Dr. Garima, how are you?
I'm good. How are you, Mike? Thank you for having me.
Yeah, of course. We're really excited. We're excited to have you on here because we're going to be in Alabama with you in a few weeks. So that's very exciting. But yeah, we're excited. Thank you very much for taking time out of your day to answer some questions for people. I do want to remind everybody that you can ask your questions in the comments, and we will be getting to them as quickly as possible. Please try not to make them too personal. We don't really want you printing out your chart on the comments here on YouTube. So go ahead and give us your questions, and Dr. Gupta will try and answer them as best she can. Before we start, though, can you give us a little bit of a background of who you are, what you do, and all that?
Yeah, sure. So I'm a medical oncologist. Like you said earlier, I'm at University of Alabama at Birmingham. I joined University of Alabama in September 2023. So been here over a year or so at this point. In terms of the NET background and how I got interested in neuroendocrine tumors, so after medical school, I spent a year and a half, 2 years at the National Institutes of Health with Dr. Carol Pasak. As many of you may know him, he's a renowned pioneer in pheochromocytoma, paraganglioma. And it was in his lab that I got interested in neuroendocrine tumors. So I continued to work on my research during residency after I left NIH. And for my fellowship training for hematology oncology, I did that at University of Kentucky. And I was so fortunate to have two mentors there, Dr. Lowell Anthony, as well as Dr. Aman Chauhan. So that's where I did my fellowship with two amazing people who are both pioneers in the neuroendocrine tumor field. And then after that, right after my oncology training, I moved to University of Alabama. And I do both GI oncology as well as neuroendocrine tumors. It's kind of split. And my practice is building up quickly.
That's great. Yeah, actually, it was funny. I said University of Miami, and that's where Dr. Chauhan is now. So, so what really drew you to the NET field personally?
I think it was, with oncology in general, I think, the relationship you have with your patients is very special. I am very personal with my patients. I love, interacting with my patients. And the other thing is that there is such a need for research when it comes to neuroendocrine tumors as well as other cancers. So oncology is a special field in the sense that you have a very special relationship with patients, but also there is so much research going on. So you have the personal aspect of it, as well as the scientific aspect of it, that draws you to it, because there is so much that needs to be done, and we are, evolving every day. New treatment options are coming out every day, but there is definitely still a long way to go.
Sure, absolutely. What do you think? You mentioned Dr. Anthony, Dr. Chauhan, two guys that are. Uh, I don't know if you can find that many people more excited than they are about the field of NET. Um, what to you, what sets the NET community apart from other diseases, do you think?
Yeah, I think it's a very close knit community. So I started attending, NANETs, and being a part of this community when I was in fellowship. Unfortunately, at that time, COVID was going on, so I couldn't really meet a lot of people in person. But since I have started attending conferences in person, having people who are so dedicated, I think this is such a rare, used to be considered a rare diagnosis. If you compare it to other diseases, still could be considered a rare diagnosis. But um, you know to have people like Dr. Anthony, to have people like Dr. Chauhan, who are dedicating so much time, working on these tumors, helping patients who have been misdiagnosed, for a long period of time, have not had access to centers where they can get the novel treatments or the newest treatments that are available now. It was just inspiring to be mentored by them, and of course they're still my mentors. So I think what really sets the community apart is how people like you are working on giving access to patients, providing information to patients. There's so much dedication, not only from physicians, but also from organizations like NCAN, which are helping get the word out and making sure patients get diagnosed appropriately and get treatments, the best treatments that are available out there.
Awesome. Awesome. Yes, absolutely. Um, I did want to ask, we got a question up here. If a PNET is successfully removed and there are no known METs, what kind of follow-up would you recommend?
So it definitely depends on, I would need to know the more specifics of the tumor, know if you have had genetic testing, because PNETs can be associated with genetic syndromes. So we need to take your age in mind. We need to make sure that genetic testing has been done, and you are being screened for other tumors as well, other types of cancers that may develop if you do have a genetic syndrome. So all those things are very important to keep in mind. So the follow-up would depend on that. Usually we would do surveillance. You would need a surveillance plan with imaging, as well as lab tests that can be done, depending again on all those other things that we need to know before I can tell you exactly how many months. But we would create a surveillance plan for you based on all those things.
Yeah, I think that's it's really hard to say one specific thing because that's the thing with NETs is there's no one way to treat it for sure. For like a newly diagnosed patient, because I think that is uh, we did get a follow up here. It said I'm 70, no genetic predisposition.
Yes, then I think you just need surveillance scans about every 6 months or so. Again, I don't want to say too specific without having all the information and looking at your pathology report and everything. But just uh, every 6 months sounds reasonable to me with CAT scans.
Perfect, perfect. So for like a newly diagnosed patient, um, what would you say is like the first thing that they should do when you've been diagnosed with NET? What is the first piece of advice you would give to a newly diagnosed NET patient?
So the first piece of advice is making sure that the person who is treating you is aware of neuroendocrine tumors, and um, has access to guidelines, which everybody should. And if if they are already a net expert, then you don't need to go anywhere. But if they are not, I would highly recommend getting an opinion from a net expert anywhere around the country. Now, I think there is many of us. There's at least should be at least one of us in every state at this point. So, going to an academic center where there is a net expert, an opinion from a net expert is very important, because this disease is so heterogeneous, and your treatment plan needs to be made in a multidisciplinary setting. So having access to a team like that, where you're meeting a medical oncologist, a surgeon, your case is being discussed in a multidisciplinary tumor board, is very important. So that would be the first step, I would say.
Absolutely. Yeah. Getting to a specialist. Getting to a specialist is super important, and also make sure, you don't necessarily, you may not necessarily be near a specialist, but try and find one near you and see if they'll work hand in hand with your local doctor. So you've participated in many studies and stuff like that. Can you elaborate on any of the things that you're possibly working on currently?
Sure. So, um, I will tell you some of the basic research that we're working on, as well as a clinical trial that we now have open at UAB. So my personal interest in when it comes to neuroendocrine tumors is looking for more novel treatments. So my research, I'm working on translational studies with two scientists at University of Alabama, who are amazing. And our goal is to look at different combinations of drugs to see if we can get a higher efficacy and a more durable response with combining some of the drugs that are already out there on the market. So that's a brief overview of what we are doing in the lab. In terms of the clinical trial that is now open at UAB is the NET retreat study, which some of you may know about. So this study is looking at patients who have previously received Lutathera treatment and have had a response for at least 12 months. A response means that the tumor has not gotten worse in that period of time and has either responded or remained stable for 12 months from the last treatment. And if the tumor gets worse again, you can be given 2 more doses of Lutathera. So that is what the NET retreat study is looking for. There is some retrospective, meaning data from other studies in Europe, which have looked at patients, who have already gotten it, but it has not been done in a clinical trial setting in the United States. So this trial is open and accruing at many centers, and University of Alabama is one of them. So if you think you would be a candidate, there is information available on clinicaltrials.gov. You're also always welcome to reach out to anybody, any of the sites that may be closest to you.
Okay. More recently, hold on one sec. So we do have a comment here, and I do want to also, please, let's make sure we're being civil about this. So I don't know how this is going to go, but I have someone in the chat, the comments here. They said that a CT scan every 6 months is too often, and every time you receive one, it increases your chance of getting any type of cancer. We need better methods of protection of detection. Do you have any thoughts on that? Is that something we should be working out?
Yeah, like I was saying earlier, I need to look at the pathology report. I need to look at how many, lymph nodes were positive, what the size of the tumor was. All those things are important in terms of how frequently we need to do surveillance imaging. So that was the reason I didn't want to be too specific.
Yeah, I think also it's one of those things, like you said, you got to make sure the juice is worth the squeeze, so to speak. If something's really, really aggressive, you're going to have to go into the CT machine. But quick question: is there is there other imaging modalities that are around that are or anything coming up that you can tell us about that are better alternatives or other
Yeah.
alternatives?
Yes, of course. Besides CT scan, there is a MRI scan that can be done. There is a dotatate PET that can be done. So those are options as well. It just depends on what is going to be the best test in the setting that we are talking about. So for a pancreatic neuroendocrine tumor which has been resected, you don't necessarily need to follow with dotatate PET scans. It just CTs and MRIs are good for surveillance scans when we are talking about. Some people like to also alternate the CTs and the dotatate paths, but if you look at the guidelines, they actually recommend anatomical imaging. Anatomical imaging meaning CT over CT and MRI.
Okay. So it is, it is in the guidelines, but it is a case by case basis. There
Correct.
are other options. And yeah, it all depends on the doctor you get. I don't think anybody's automatically going every 6 months.
Right. Exactly.
Um, in terms of this CT scan, can it be detected without any contrast or dye?
I would say it makes the scan less ideal and less sensitive when we are giving it without contrast and dye.
Okay. Okay. Um, Lately, mental health has been like a major hot button thing for the past few years with just the general public and stuff. And now it's starting to get into the net world. And I don't think any disease at all is exempt from it. Um, have you seen any kind of advances in how the mental health part of NETs is being treated and kind of like helped? Like what are some things that you've been seeing lately?
So I think having a community like NCAN is important. Being a part of a support group, having there are different avenues that are available. There might be a support group available through the cancer center that you are being seen at. And there are dedicated mental health professionals as well at cancer centers that may or may not have experience with neuroendocrine tumor patients, but I don't have anything specific in terms of particularly for that, but I think just having a good team and being part of a community like this is important, and having a support group through your cancer center if available is important too.
How much do you think that mental health fits into a treatment plan for NETs? And is that a part of any guidelines?
So I think it definitely fits in, because sometimes there is uncertainty about there is of course this is a diagnosis, life altering diagnosis, and people hopefully, like if you're doing a good job, we are improving the survival and life expectancy. So I think with neuroendocrine tumors, as a matter of fact, for any cancer, right? I mean, you mental health is very important. This is, like I said, a life altering diagnosis. So having a support group at your cancer center, talking to a psychologist, getting uh, being a part of this community, all those things are going to be very helpful.
Absolutely, absolutely. Um, so you did a lot of study. You did some stuff in NIH, and you obviously studied a little bit of the genetic alterations and stuff like that. Can you give us a little bit of information about how that's been kind of evolving over the past couple of years?
Yes. So with as we were talking about, specifically that pancreatic neuroendocrine tumor question we had, there are genetic syndromes such as VHL and MEN1 that are associated with neuroendocrine tumors. So it is part of guidelines to consider testing. Genetic testing for patients with pancreatic neuroendocrine tumors, as well as other types of neuroendocrine tumors. Again, depends on the family history. You need to, when you go meet your provider, it's very important to get a detailed family history, see if it's something that's running in your family. I don't think we've had a major leap in terms of genetic syndromes when it comes to neuroendocrine tumors. There is definitely ongoing research. But when it comes to pheochromocytoma paraganglioma, when I was at NIH, there was a lot of research going on these tumors at that time, and many new syndromes that are associated with pheochromocytoma paraganglioma were specifically, found at around that time. So, but when we're talking about neuroendocrine tumors, not particularly about pheochromocytoma paraganglioma, there has not been anything major that has come out that is going to be, changing our practice.
Sure, sure. Are there contrasts in dyes that are less than radioactive dyes? Wait, I'm sorry, less dangerous than radioactive dyes. The goldonium within MRI contrast dyes is toxic. It can stay in the body for months, years. Are there alternatives that you know of?
So the contrast, the iodinated contrast that is given with CTs, these are the standard dyes that we use. The iodinated contrast given with CTs, the gadolinium, like you said, given with MRI, and then of course there is a different type of special dye, the radioactive dye that's given with the dotatate PET scan or another type of PET scan. So I agree with the comment that we need safer chemicals, but it just depends on the risks and benefits of what is being done, and what we need to, why we're doing the scan, what we need to do the scan for. So I agree there's need for safer chemicals, but this is what we have. These are the options we have right now.
Yeah, yeah. In terms of diet, how often do you get involved with a patient and their diet, and what do you see are the major flare-ups or things that kind of flare up the disease?
Yeah, so I mean, of course, patients who have something called carcinoid syndrome, where you are secreting something called serotonin or the metabolite, 5-HIAA. There are certain foods that can flare up your carcinoid syndrome. So if we have a patient with carcinoid syndrome, we definitely have them see the dietitian or the nutritionist at our academic center. There can be, we create like a plan for them in terms of which foods are going to be best, which foods are triggering their flavors. There are some known foods, of course, that are nuts and wine and things that can trigger carcinoid syndrome. So we make patients aware of that. The other thing to keep in mind is the diarrhea that can happen with carcinoid syndrome, and that can really dehydrate patients. So it's very important to get that those symptoms under control, and if needed, not always, but if needed, a nutritionist or a dietitian can be involved in your care as well.
That's again part of that multidisciplinary team. Very, very important. And going to like a net specialist or a center of net excellence, it's really important that you do that, because those are huge things. I'm just kind of going through this. Okay, this was more of the statement of the CT dye and using it too much on people without a predisposition to that. So some of the new treatments. I know you can't go too deep into stuff, but uh, what kind of promising advancements have you seen in terms of treatment over the past couple of years?
Yeah, so I will talk about some of the recent data that was now actually last year and was also discussed at the NANETS conference in November. So one of the studies that is being talked about is NETTER-2, which is looking at giving Lutathera earlier in the treatment plan instead of waiting for progression if you have been receiving octreotide or lanreotide. So this is more applicable for patients who have a high tumor burden, as well as having symptoms. So this is not something that should be for everybody. It needs to be, considered based on your tumor grade, needs to be considered on how much tumor there is in the liver, in your body, in the rest of the organs. But this is an exciting option to have because, we do need to sometimes debulk and get tumors under control faster, depending on the grade and the bulk of disease. NETTER-2 was an exciting study that has been presented in the past year. The other development we have had is a drug called cabozantinib. That is a type of targeted treatment called tyrosine kinase inhibitor. So this study was looking at a heterogeneous group of patients. So it included pancreatic as well as extrapancreatic. So tumors that started in the pancreas as well as outside of the pancreas with advanced disease. So this was not localized disease, advanced disease. And this was given to patients who had already gotten different treatment options in the past, and it did show efficacy, an overall response rate of 20%. So 20% of patients who were on the study showed some partial response for patients who had pancreatic neuroendocrine tumor. The responses were lower if you did not have pancreatic neuroendocrine, but this is definitely an exciting treatment option, and that we can use for patients who have already maybe gotten the somatostatin analog, Lutathera, Cape-Tem, everolimus. So this is something to keep in mind. The other thing I will mention is of course, the other agents the other PRRT agents that are now being tested. So these are, as you know, Lutathera is a beta emitter, so it emits beta particles. Now we have newer agents which are emitting alpha particles, and the reason to use this is because they are more potent and cause less tissue damage. So there are ongoing trials looking at patients who have received Lutathera in the past or who have not received Lutathera or any type of PRRT in the past. So that is something the NET community is really looking forward to as well.
That's great. That's great. We have a question. Do you deal with POFARA? POPARA? That's been something that's been kind of becoming more prevalent over the past few years. Or do you consider them different from NETs? I don't think they're different from NETs, but
yeah, I mean, there are type of neuroendocrine tumors, and they have a little bit of uniqueness about them. I mean, in terms of the different hormones they can release. So they are unique in a way. So, but they are a type of neuroendocrine tumor. And in terms of me dealing with pheochromocytoma and paraganglioma, I would say most of my practice is gastroenteropancreatic neuroendocrine tumors, and I do have some patients with pheochromocytoma and paraganglioma as well that I'm treating. Yes.
okay. Yeah, I know that PhoParas have really kind of come to the forefront over the past since like 2021, 22. So I'm glad it's another thing that we're kind of servicing here. So I know that in NETs, that's something that NCAN kind of talks about a lot is with certain doctors, whether it be primary or whatever it is, if they are not a net expert. I know a lot of people get worried because doctors are by and large, people kind of hold them on a pedestal, and just kind of take their word for what for everything. But knowing the importance that there is behind seeing a specialist and seeing somebody who has dealt with nets and whatnot, how would you kind of what advice would you give to a net patient on how to explain that to a doctor that may not understand why they're not going along with their treatment plan, and they think they need to kind of divert away and go to somebody else?
Yeah, I would say, I guess people just need to physicians need to, who do not see nets, there is a need to understand that this is a very unique disease, and it is very different from any other type of malignancy. The treatment is very different from any other type of malignancy. So I don't think I don't think the oncologists who do not usually see a lot of net patients should take offense. I have had patients who, were diagnosed with a grade 1, and then when it was reviewed at our center, it was a higher grade. I have had situations where, we know there is advanced disease and a rotated PET scan has never been done. So I think because it is, there is still a need for awareness and about these tumors, and if you have not spent time training on it, it can make it more challenging to treat. So I think I don't think I've had a lot of trouble with my own patients if they come for a second opinion. Actually, um, a lot of them are not self referrals. They are referrals because the oncologist is aware that it could benefit the patient from going to at a net center. So um, I think we're moving in the right direction when it comes to that.
Yeah, we have full tilt in the chat saying, I think we should become it should become practice that a general oncologist should direct people to net specialists, knowing that they have more tools in their bag. I think that's it's definitely important to be able to I th- understand humility a little bit, and I think what a lot of people worry about is saying I don't know.
Yeah.
Um, but sometimes it saves a life. That's just my, like if I don't know something, but I will find somebody who does know, as opposed to just this is what I think it is. So, um, we have another question. Can you explain why sometimes watchful waiting is the best option?
Yeah, that's a really good question. So, um, it depends on the grade of your tumor, the location of the tumor. Watchful waiting can definitely be considered, and the reason is because if you have a low grade tumor, some, of course, the grade 1s and a low grade 2, the growth of the tumors can be very slow, and if you do not have a tumor burden that is going to affect your organs or is not causing symptoms, I think of it kind of like having a toolkit, and you have, these 5 options, let's say, that are really good treatment options. It's strategizing when do we need to use that tool,
Yeah,
and not using it up too early. So for that reason, I would say, again, this is a very personalized treatment plan. So if you have a high burden of disease and a grade 3 tumor, this may not, it's not going to apply to you. So again, just to provide caution that this is not applicable to everybody, depends on the grade of the tumor, the location of the tumor, the symptoms, that you are having in terms of watchful waiting, but it should definitely be considered.
Yeah, I think I definitely think that I know there are certain people who think on the more aggressive side, but there are definitely other things that you should consider before just jumping under the knife for sure. Um, Clinical trials. There's a big misconception, and I have had this conversation before with a number of other doctors, but we keep getting new people that come on and view these things, and thank you guys for joining us. Really appreciate it. But clinical trials, what what are some of the things that you think a patient should ask about before entering a clinical trial? I know a lot of people are worried about, because you know they haven't been informed, but a lot of people are worried about placebo. A lot of people are worried about medical the coverage, the whole process behind it. Everything from the travel to the boarding to the being in a doctor's office, having to wait, and be observed and stuff like that. So what are some things that you could impart on everybody here to kind of ease their minds a little bit about
Yeah,
getting involved?
yeah. So first of all, clinical trials are the only way we can, you know, test treatments and get more treatment options for, for our patients. So clinical trials, I know it can be scary, but I'll start off with different phases of clinical trials. So clinical trials is three phases. There is phase 1, phase 2, and phase 3. Any drug that is in the lab or has been tested in the lab in animals goes through something called phase 1. So phase 1 is coming straight out of the lab. It's really looking at the safety of that particular drug or agent that is being tested. Then if we find that the drug is safe, it moves to a phase 2, where we are looking, there are higher number of patients that are enrolled, and we are looking at what the efficacy of the drug is and how well it's working. Then phase 3 is where placebo comes in. Okay, and it's not necessarily always placebo. It's basically you're comparing it to either a drug that is already approved for that particular disease, or it could be placebo. Okay, so it really depends. I don't want people to think that every clinical trial has placebo. It's important to understand, is the clinical trial specifically for your type of tumor, for neuroendocrine tumor, and what phase the clinical trial is in.
Absolutely, absolutely. Now, with a placebo, just to give a little bit of, again, it's all about, uh, you know, it's the only way to advance medicine is by doing these clinical trials. But I think what people are worried about is being asked to come off of medication that's working or is doing the job okay, and then taking a placebo and then not being treated at all.
Yeah.
Is that something that happens? Is that what goes into a placebo kind of situation?
Yeah, so most of the time, you will not be enrolling in a clinical trial that is an interventional clinical trial, in terms of what is if there is a drug involved in it or any type of treatment involved in it. If your existing treatment is already working, most of the time, the reason to enroll in a clinical trial is if your tumor has stopped responding to the treatment that you're already receiving. So that's the first thing to know. And then the second thing, as we were talking about earlier, not every clinical trial is going to have placebo. So, your clinical trial team will definitely be telling you that upfront, that you may be randomized to an arm of the clinical trial that has placebo. And it is done in a randomized fashion it is literally a computer that is randomizing you to either receiving the treatment. This is not being done intentionally by somebody that is a part of the clinical trial team. So it's very random computer system randomizing either to the treatment arm or to the placebo arm if the clinical trial has a placebo arm.
Okay, that explains it a little bit better for sure. And yeah, that is the other thing that I don't think a doctor or somebody who's been with a doctor for a while is gonna tell you to rock the boat when you don't need to. That's
Right.
I think that's again when doctors are pitching and talking about these clinical trials, people are excited, and then when the time comes, it's nerve-wracking, like you said. It's very, very scary thing. But you know, it doesn't necessarily mean it's for you. So I wouldn't just go jumping in for clinical trials if things are under control, if you're living pretty comfortably and stuff. So let's see, we have it's hard for people to find out how to find a clinical trial. Dr. Gupta, do you have any resources for something like that?
So if you just there is a website called clinicaltrials.gov, which is looking at all clinical trials that are available in the United States. So that there is a patient website as well as a provider area on that. So I usually give all my patients a link for that website. They can search neuroendocrine tumor there and look at. I get asked in my appointments, hey, have you looked at this clinical trial? What do you think of this one? This is open at this center. So I think to be an advocate for yourself is important, and to use that website. I know a lot of my patients use it, is important. Is there some place on the NCAN website that we have access also to ongoing clinical trials, Mike?
And we just direct them to clinicaltrial.gov,
Okay.
and it's a matter of just filtering it out, finding your
Exactly.
area, all that kind of stuff.
Right.
Also, we have the clinical trials are often no cost to the patient. That is correct. That is correct in most senses of the word. But there might be upfront costs that you may not know about. So if you have to travel somewhere to a medical center, you may have to lay out the money. You just need to figure out how you're going to get reimbursed, and stuff like that. That's what the most important thing is. But you do have to check with the drug company, how you get reimbursed, what you're getting reimbursed. Sometimes they write you a check. Sometimes they give you gift cards. That's it's something that the patient really has to do their due diligence before they get involved, for sure.
And I will just add that anytime we are enrolling somebody, like of course we have patients from out of state or who live many hours away who are coming for evaluation for clinical trials. So exactly like you said, it depends on the clinical trial. There is the cost of coming to that medical center for an evaluation is of course not covered. But once you are enrolled in the clinical trial, it depends on the clinical trial whether lodging is covered. There may also be resources through the cancer center. I know we have resources through our case management and social work team where they can help with those resources in terms of lodging and gas cards, those type of things that are available. So and you usually you don't have to go don't have to do a lot of work. The clinical trial team is very good about letting the patient know that, hey, this is available or reimbursed through the clinical trial, and these are the resources that are available even outside of the clinical trial through social work.
Yes, yeah, I think that's a very underutilized resource, is the social workers that work in those hospitals and stuff. They are the people that are they're there to provide that information, to provide that help. That's what they're there for. So take advantage of that if you're able to, and at any medical center you're a part of. Yes, we are talking about life and death. Yeah, people will do anything that they. Yeah. So yeah, Dr. Gupta, thank you very, very much for spending time with us today and answering some questions for everybody. We really, really do appreciate it. If anybody has any more questions and you're in the Birmingham, Alabama area, March 15th, we'll be there. NCAN will be there. We have our Net Patient Conference. It is going to be great. We have 5 amazing doctors giving some great presentations. I don't have the agenda in front of me, but Dr. Gupta, what are you going to be presenting on?
Yeah, I'm going to be doing the first talk, kind of talking about all the basics of neuroendocrine tumors and the 5 things you should be asking your oncologist.
Oh, perfect. So we're not gonna talk about that right now because we want you all to come to the conference. So yeah, please make sure if you're in the area, come. It's a once in a lifetime type of opportunity to be in a room with amazing net experts from all over the country and from locally as well. It's huge. It's community. You'll be there with a number of other net patients. We make sure that we put things in the round. We don't do classroom style. This is a networking opportunity for everybody. And if your answers weren't if your questions weren't answered here today, we do have 2 question and answer periods that I'm sure the doctors will be very happy to answer your questions as well. Once again, if you have any questions on these events that we have coming up, go to netcancerawareness.org. Follow us on social media at netcanceraware. And we'll see you in 2 months. We have Dr. Sarah White, who will be doing a podcast with us, and then a live stream Q&A as well on a Wednesday. So thanks everybody again, and we will see you next time.
Thank you.